first of all, I'd just like to welcome you. This is the osteoarthritis education session that comes along with the GLAD program that we currently run here, and which is run at a lot of different places, different physio practices. I'll talk a little bit more about the GLAD program as we go along. But essentially, what this is a way for you to understand what is arthritis and how does it affect you. What are the signs and symptoms, and how do we diagnose it? How do we work out what's going on, and then how do we manage it, and what is the good evidence for the different various treatments that we've got. We treat osteoarthritis now very differently than we did, say, 10 years ago, where it was more kind of passive treatment. So we're looking to find an answer or a cure or a fix to our arthritic pain. And now it's a lot different from that in terms of our understanding of the way that osteoarthritis affects us, but also the way that we deal with pain and we manage pain as well. So we'll talk a little bit more about that as well. So what I'll do is I'll start sharing my screen because we've got some slides. So I will do that. And I'd just like to say as well, for those that are listening, and we are going to record this so we can have it, send it out to anyone that has missed out on the sessions. But essentially, I want this to be as interactive as possible. So if you find that you agree with me, fantastic. If you disagree with me, I want you to tell me as well. I want you to tell me your stories, how it affects you as well, and any questions, obviously, that you've got along the way, because this is a very personal thing, arthritis, and affects everyone slightly differently. So we know that we're all individuals when it comes to this. But what is important is that through the research, we've got some really clear understandings of the way that the best evidence for the management of arthritis, and we're certainly going to talk about those in more detail. So I will, first of all, I'd like to certainly acknowledge of the GLAD program. The GLAD program is a program that was developed in Denmark, and GLAD stands for Good Life with Arthritis in Denmark, because they kind of started it, and it's now taken over kind of the world, and it's in countries all around the world. Certainly, Australia has contributed a lot to the research in and around the GLAD program or managing arthritis. And so we know a lot about it as well, and we're getting very knowledgeable the more that we go along, the more that the research is out there. So the people in Melbourne, in La Trobe University, have contributed a lot towards the research as well. So they've been fantastic, and a lot of the practices, including us, are continually contributing to a lot of the research by collection of data. So with all our people that join the GLAD program, we measure them before and after, and how they progress and how well they've done, so that we can use that data to obviously improve. But also, what we're wanting to do is to lobby some governments and some other funding bodies, so that we can get some subsidies for these programs as well, because it certainly arthritis, as we'll talk about in a little bit, has a major impact on the health system. So over $5 billion each year is spent within the health system with management of arthritis, and a lot of that money can be spared with a really good knowledge about the real evidence to support the most effective treatments. So just to give you an understanding, a quick snapshot of the GLAD program, the evidence is very strong, and to give you a little giveaway about what the evidence says is that the evidence is very strong for exercise-based management, education and self-management. So education around what is arthritis, how does it affect me, what are the good ways that I can manage it myself, and what is the pain with arthritis as well, and how does it affect me as well. So education around that is really important. And the other strong part of the evidence for management of arthritis is weight management. And there's some strong evidence, which we'll go into a little bit later, about the importance of weight management when it comes to managing osteoarthritis. So this is one of the education sessions. The second part of the education session is more around how can you personally manage your own arthritis. So this first session is, what is it? What are the treatments out there? What is the good evidence? What is the not the evidence that doesn't support various treatments? The second session is more focused around what self-management strategies I can do to help manage my arthritis and my arthritis pain as well. So the education session is very important, but the core of the program is the exercise program, and the exercises that we do it in small groups within the clinic, and we do that twice a week for 6 weeks. So there's 12 sessions, 12 exercise sessions. And we progress all the way through, and everyone starts off at a different level, but everyone joins in and we progress as we go along. Why it's 6 weeks and not ongoing is because we have a baseline measurement at the start, and then we measure outcomes at the end, so that we can then have put that data together, so that we can again use it for education, research, and obviously lobbying for funding. But there's a lot of people that will continue on after that. But it's really important to understand that it's not a set and forget. We just don't do the exercises and then that's it. It's very important to do it. But what we feel with doing a 6-week program is that you are then lifted. Your function is lifted. You've achieved some goals. Maybe you started doing some activities that you didn't do before, and as though that increase in activity level again will help to manage that arthritis in itself. So becoming more self-managed is really important as well. So what we're wanting to do is the objective of this is to, and I guess my biggest goal is to get across to my client population that comes to me with arthritic pain, is for them to understand that this is not about finding a fix or a cure or making me better. And we have to really understand that this managing osteoarthritis is about management, and how I personally can improve my quality of life and my function in the same time that will reduce my pain. But what we're really wanting to do is to understand that this is about managing it rather than fixing it, and it's really important to understand kind of how we go about that as well. So how common is osteoarthritis? Well, I have to tell you that it is easily the most common lifestyle disease. So of all the lifestyle diseases, so a heart disease or diabetes or any of those bigger comorbidities, this is the most common of those diseases. It's much more common than high blood pressure, heart disease, and diabetes. And we know that it is, Over 2 million people have hip or knee osteoarthritis, and that figure is a little bit older, and I think it is a lot more common than that now as well. There are over 1.5 million consultations to the GPs every year about osteoarthritis. And we're not just talking here, we are focusing this talk on hip and knee osteoarthritis, but we have to understand that osteoarthritis is very common throughout the body, and not just in the hips and the knees, whilst the program, the exercise program is targeted to those joints. But certainly the education and the advice and the knowledge that we get from these education sessions is really important, because that's about managing our arthritis pain. And that can affect our hands, it can affect our neck, our spine, our back, our knees, our ankles, elbows. So it's very important for us to understand that the information here is not just about hips and knees. 30% of people aged over 50 and above report hip and or knee pain. So, and I think that there's another study that I've read that's a little bit higher as well. Osteoarthritis is also the second most common cause of retirement due to ill health, which is really important too. So it is a debilitating disease, and it is a progressive disease, which we'll learn in a little bit. And also the other thing is that people with osteoarthritis or chronic pain, they have a much higher rate of psychological distress or stress and anxiety as well. So there's some studies to say that if you have osteoarthritis, you're 5 times more likely to have stress or anxiety in your life as well. So there's other things that affect our lifestyle, not just the physical nature of osteoarthritis. So what is osteoarthritis? It is a disease, and it does affect joints throughout the body, whether that is the knees or the hips, as I said, the spine. It would be interesting to know, and normally when we do this in the clinic, I ask a question. I say, well, what's the most common joint in the body that's affected by arthritis? And it's going to be a little bit difficult doing it online. But a lot of people think, oh, it's the knee. Knee arthritis is the most common, or hip arthritis is the most common, or neck, degeneration is the most common. But it's actually hands. Hands are the most common area of the joint that's affected. And sometimes it's our knees that affect us more, but it's more common to have osteoarthritis in the hands than anywhere else. We used to think that osteoarthritis was a wear and tear disease. Our joints are wearing away. The more that we use our joints, the more that our joints will wear away. And we now know through the research that that's actually not the case. So what we do know is that it is osteoarthritis is a disease that is a lifelong disease. So we can't cure arthritis like we can, hopefully, this COVID crisis that we're in. We can't fix it, we can manage it. So we have to understand that it's about managing it. But what are the misconception is that the more we use our joints, the more that our joint will wear away. And it's simply not true. And there's been countless studies that have shown that. So we're stopping saying that it's a wear and tear disease, but it's more a breakdown of the cartilage and other aspects around the joint that happens. So the bones can reshape. We can get lumps happening around the bone. We can get inflammation happening in the bone. I might just get everyone, I'm just going to pause here and just ask if everyone just mutes themselves. If you can find the mute button, that would be great. Just getting a bit of feedback. And if you do have any questions, please unmute yourself and speak up, and then I'll stop and we can chat and hopefully be able to answer your questions. If not, I'll leave plenty of time at the end to be able to have time to go over. Just to let you know, this talk normally is around an hour and a half, depending on people's chats and everything. So that's a bit about the time frame, but I'm more than happy to be flexible when it comes to that. So just getting back onto what is osteoarthritis, it's a disease that affects the whole joint. So it's not just the joint surface. And what's important to know is that osteoarthritis affects different parts of the joint, and different parts of the joint can be pain producing. So it's not just the joint surface that can contribute to the majority of the pain. So when we're talking about arthritis, we're not just talking about the cartilage on the joint surface that has broken down. And so I think that's really important to understand, that it's not just about the cartilage or the wearing away of the cartilage, because other structures around the joint can produce more pain and be more debilitating than the joint surface itself. So that's important to understand. So we don't say wear and tear anymore. We use a lot of other words to describe it. One thing that we used to do when we used to manage arthritis is the first thing that doctors do, and a lot of doctors still do this because it's common and it's easy, and we've been doing it for a long time, is if I've come and I describe to the doctor I've got some knee pain or some hip pain, well, the first thing that I'm going to do is get an x-ray just to see if we've got any joint narrowing. And whilst that's fine to do, it doesn't always give us an accurate portrayal of the extent of arthritis which is in the joint. There are, I see a lot of patients that come to me with very, very mild pain, but they have x-rays with severe joint degeneration and joint narrowing. And so one of the problems around this is that they become quite fearful and anxious around the extent of their scans, but in reality, their symptoms are quite mild. So their scans don't always relate to the symptoms that we're seeing. So what's more important for us is to have a good thorough assessment and then to work out the extent of the disability as related to the assessment as opposed to the scans. And we also know that there's so many different things that influence the pain that we experience. So it's not just, as I said, we don't correlate it to the extent. So there's so many different aspects. Depression and anxiety, my past experiences of pain, all of these other factors can influence how much pain or how little pain I've been experiencing as well. So muscle weakness or inactivity as well can affect it as well. So these are some of the things that that can contribute to the way that we experience pain. So other comorbidities like being overweight or fatigue or diabetes or heart disease, they can play into it and make our experience of our osteoarthritis more. And as I said, muscle weakness can have a profound impact on it, because we've got some instability related to the strength and stability, and that can contribute to the pain. Which is quite different from the physical nature of the degeneration itself. How much load do we put in? How stressful our life is, that can contribute to the pain itself. And as I said, stress, anxiety, our own beliefs around what is pain, what is osteoarthritis, and what to what extent I will need to be disabled or abled can have effect on it. So how resilient am I as well? So when we talk about the risk factors, we kind of categorize them into two categories: these non-modifiable risks and the modifiable risks. So when I'm talking about non-modifiable or modifiable risks, is what affects our arthritis, which is either I can control it or I can manage it, or it's got nothing to do with me, it's just the way I am. So firstly, the non-modifiable risk factors, which is your age. The older you are, the more likely you're going to have arthritis. It's as simple as that, and there's nothing we can do about it. Certainly, there's the chances of having arthritis certainly increases considerably after we turn 50, and then certainly after 70 and 80, the chances that we've got arthritis is even greater. That's just the way it is. If we're male or female, that affects it too. And that depends on the different joints in the body. But generally speaking, far more women have arthritis than men. But in saying that, men tend to have more, be affected more in their knees than women, which is, and that's just the way it is. And it might be because men have more of a physical nature for their work, say, for instance, but we don't really know. And the other thing is your genetics. You are far more likely to have osteoarthritis if your parents had osteoarthritis, and that's just the way it is. So what we have to understand is that all of these things contribute to our risk factors, but we can't change them. But what we can change, I'll go back to it, is the things that don't that we are able to change, our modifiable risks, and we'll go into that in a little bit more detail in a second. So how do we diagnose osteoarthritis? I talked about X-rays that we get, and I'm not saying that we shouldn't get X-rays, but what I'm saying is that I will get X-rays when I think that it's going to affect my management. But if I'm very confident with the diagnosis of osteoarthritis, then I know that an X-ray is not going to change the way I treat or manage this person with osteoarthritis, then there's no real strong need to get X-rays. Because what my decision making will be, whether I refer to a surgeon or not, is what management have we done to date, and if we haven't done a good, strong strengthening program with education in there as well, then I will do that first before we launch into getting X-rays. Because X-rays, whilst they can show us a lot, but they don't show us everything. And they can have a negative impact on it, as I was saying. If we see some wear and tear and some degeneration in my knee, but I don't have a lot of pain, maybe my perception of how bad my knee is gets worse because of the fact I've seen that, and what the radiologist reports a significant loss of articular cartilage, and those kind of things. They're the kind of things that potentially will make us catastrophize over how bad it is. Whereas in reality, I might just have some mild pain and symptoms, and that doesn't correlate to what I'm seeing on the X-rays. So we don't jump at getting X-rays, but sometimes we will. When we will get some X-rays is sometimes when we're not sure of the diagnosis and we just want to confirm this. We also want to rule out any big nasty diagnosis, bone cancer, for instance, just to throw in there. But that's not very common, so we won't do that all the time, and certainly not standardly. So how do we do it? We certainly we have a good strong assessment, get a diagnosis, and that diagnosis is based on the examination that we have, the symptoms and the signs and the symptoms that you experience as a patient, and also your risk factors, your genetics, your other comorbidities which contribute to the chances of having arthritis as well. And we make a diagnosis, and then we formulate a plan or what we're going to do, how we're going to manage this. What are the things that we need to do? What are the most important things that we need to do to manage this arthritis? So that's how we generally go about it. So what is the joint? What structures, I guess, can contribute to the pain as well? So the articular cartilage or the joint, articular cartilage is the smooth surface on the bone, and that is very important to produce a friction-free, or as friction-free as we can get, environment for the joints so that they can move easily. The articular cartilage also absorbs shock, and it can distribute that shock over a wide area, so we don't sustain damage. But it's important to understand that the articular cartilage on the bone doesn't have a good blood supply. It doesn't have a lot of nerves that supply it as well. And it's interesting, how then do we get the nutrients into the cartilage? And what we understand now, after doing a lot of research, is that articular cartilage breaks down and remodels or synthesizes the cells, and the structure around the cells degenerate and regenerate. And this happens over time. And what good articular cartilage or healthy cartilage is when we get a good balance between that degeneration and that regeneration, or that breakdown and that synthesis of that cartilage. So when we get damage to that, so we can get damage where we can get traumatic damage, or we can get damage where it happens over time, and this can start that breakdown or imbalance of that process, and that can lead to a degradation of the articular cartilage, and that's what starts that process. So we know that it doesn't have a lot of blood supply. So how does it get the nutrients? And we wondered this for a lot of years, but now we know that here's a joint that I've got here. I don't know if you can all see that, and I'll take my screen off in a second when I show you more about what the knee is. But here we go. If we have a good healthy joint, and I might just unshare.
Yeah, that's it. Oh, better. That's better.
Can you see me now?
Yep. Yep.
So this is the knee joint, and so this is the articular surface along the knee joint. We have the knee joint here, which has got the floating cartilage as well, which is the meniscus. But I'm just talking about majority of the articular surface, because that happens in the hip as well. So if we have not a lot of blood supply there, so how do we get the nutrients into the cartilage for that regeneration of cells to get that balance right? And what we now know is that the loading or the pressure of our weight on our joints is incredibly important. So let's think about it as if I have a sponge in a bucket of water, and I put the sponge into the bucket of water and squeeze the sponge, and then I let the sponge go and I take the sponge out, it's full of water. All the nutrients, all the water has been sucked in or into the spaces within the cartilage like a sponge. But I know that if I don't load it or I'll overload it, then we get an imbalance of that cartilage growth and degeneration. Which means one of the things that we discovered as a result of that is that loading or the pressure on our joints is incredibly important. So much so that if we have relative unloading, so I have a more sedentary lifestyle, I know that my cartilage won't get that regeneration process in balance, and I might be more likely to have a degeneration or a breakdown of that, or degradation of those cartilage cells. So that's why we now know how important it is to load the joint. So I was talking about the joint, the arthritis not being a wear and tear condition, and we have to understand that that's correct. We also know through a lot of different researchers, and I'll send you some of the research which kind of highlights this, quite detailed reading, but there's a summary which goes to understand that. But one of the studies which I think is really important is one that happened in 2018. And they did a big study with men over 50 with mild to moderate arthritis in their knees. They had mild to moderate degeneration on their knees, and that was diagnosed by a clinical assessment as well as x-rays. And there were this big group of over 50 arthritis sufferers were put in two groups. One were runners and one were not runners. And after 48 months, they came back and they retested and they rescored them and they asked them about their pain. And overwhelmingly, the group that were runners had, first of all, much reduced symptoms. So their symptoms actually decreased. And second of all, they had much less radiological degeneration happening. So what we do know from that is we won't wear our joints out by walking. We will not do that. In fact, it's going to be important to keep the balance right with our cells in our cartilage. Now I'm just going to move back on to sharing the screen again. Now, any questions at this stage? If you have a question, just unmute yourself and speak up. I can chat with anyone.
Okay.
There'll be plenty of time to ask questions later as well.
Is that me?
So the healthy knee joint, this is a knee joint, believe it or not. I don't know, I'll move back, I'll unshare it again. Knee joint here. So we have the kneecap or the patella in the tendon going up to the muscle. The tendon attaches onto the bone and from the muscle and moves the muscle. We have the articular cartilage on the joint surface here, both on the thigh bone, which is the femur, and on the tibia, which is your shin bone. And so the cartilage attaches on that, creates that friction-free surface. We also have in the knee the meniscus, which is the floating cartilage, which acts as stabilizers. It stabilizes the knee, really, really important. They used to do a lot of arthroscopes and they'd take part of the meniscus out. And whilst it reduces some of the pain early on and makes your knee feel a lot better, it really increases your chance of developing osteoarthritis later. So now they're really careful about doing any surgery in and around the meniscus. We have ligaments. Ligaments on the side hold the bones together, really important. And the ACL, which you might have heard of the cruciate ligament, that they've done their knee and they're out for a year from football. That's a cruciate ligament on the inside. That controls rotation stability. And we also have inside the joint, we have synovial fluid, which is the gel fluid in the knee, which has the nutrients. The nutrients are in that synovial fluid. but that also contributes to the nice friction-free movement that we have in the knees. So that's a knee. The hip joint is very similar. The hip joint is very similar in along with the knee, but the hip is a ball and socket joint, not a hinge joint like the knee, and the hip joint doesn't have the meniscus or the floating cartilage that the knee does. So it's more a ball and socket joint like this. But it still has fluid, it still has ligaments, it still has tendons around it, still muscles connect and move it. It just moves in more planes, so it rotates a lot more. But has the same effects of trying to keep that balance between degeneration and regeneration of these fluids. It still has the same osteoarthritis signs and symptoms of joint swelling and pain and bony changes and tenderness around the joint. So this is a little diagram just to show the importance of that balance of regeneration and degeneration to get that balance right. And so the imbalance can happen in a number of ways. Firstly, if we have trauma. So if we have trauma to the joint, we have a big power that can change the level of degeneration or regeneration. If we have load over time, so constant low load, but with too much loading without that relative unloading. And that might happen, say, for instance, a truck driver who unloads, 20 times a day. He's in and out of the truck, and it's a big truck, and he jumps down from the truck and lands on the ground, and he has that jarring 20 times a day, and that happens over time for 20 years, and that might contribute to this imbalance between regeneration and degeneration. But as I said before, it can also happen with inactivity. So we get relative unloading, and that unloading can change that balance as well. So it's important to understand that. And we also have to understand too that there's a lot of other factors that contribute to the osteoarthritis as well. As I said, your other lifestyle factors, your comorbidities, heart disease, diabetes will increase the risk of developing more. We know that if we have poor diets and lack of sleep, that can contribute. We know that if we are overweight, then that will increase the load as well, and that's really important to keep that. And also our stress and anxiety can contribute to our experience of pain, which we talked about. So let's talk about signs of what do we see with, or what are we experiencing with osteoarthritis. And I think we'll all understand that a lot of the time it's pain on movement, it's stiffness, especially after we've been inactive, so in the mornings after sleeping. We also know that it's if we sit down for a while and then go to stand up, we can have stiffness and pain in our hips and knees, especially. If in our hands, if we're moving them or gripping objects tightly, that can produce pain as well. We get hot, and we can get swollen joints, inflamed joints. We can certainly get tenderness around the joints if it's in the thumb, say for instance, tenderness around there, or in the front of the knee or at the back of the knee. So in particular with the hip pain, we can get pain, especially at the front of the knee. We can get a pinching pain at the front of the knee, and it can go down into the groin or down the front part of the leg. We can get pain on the outside or the buttock as well, but it's more common to get pain into the groin with hip osteoarthritis. In the knee, knee pain can vary. It can be at the front, at the back. It can be underneath the knee. It can be on top of the knee. We can get pain when we're walking or going up and down stairs. It's very variable when it comes to pain that's associated with osteoarthritis in the knee. But we can certainly get changes happening. If we get wear and tear happening on one side of the joint, then we can get a bowing happening in the knee one way or the other. So that can produce a deformity, which we can see with people with knock knees or a bowing in the knee. We can also we're more likely to have the knee give way than the hip. It can become unstable and weak, and it can just fail quite dramatically.
That's what happens to you, yeah.
So what happens? What is that effect? What do we see or what do we feel? Well, what's hard for us to do? But generally speaking, if you look down this list, if you suffer from a knee or hip arthritis, you'll most likely tick off a fair chunk of this list about things that are difficult for me to do and achieve. So putting on the socks, especially going up and down stairs, getting out of the chair, getting out of the toilet, which is often lower than a chair, that's hard for me to get up. And as you can see, if we're saying now, well, we're going to manage these things, so we can kind of unpack, the way that we're our attitude towards it. If going up or down stairs or getting out of the chair is a challenge, or it's hard to do, or it's painful, if we can make it easier to do that, easier and stronger to get out of the chair, then that will help to decrease the pain and make me more able to do it. And then when I'm more able to do it, I'm more able to do other things and be more active, and that feeds into that as well. So I'm going to flick it back for a second. This is the amount of pain that we've got. So this is the pain that we've got for an activity, say, for instance, going up and down stairs. So if that's my pain limit going up and down stairs, and when I go up and down stairs, so let's say it's walking around the block. Walking around the block is hard to do, and if I walk around the block, I get the pain. So I'm walking, I get the pain, I stop walking, and the pain settles down. So we can either, to make sure that we don't go through that threshold of pain, we don't go through that threshold, this is the limit to my pain, then we can just walk to the street, to the end of the street and back, and my pain doesn't come on. So that's really easy. Or I just walk around the house and I can really manage that. But we'll never be able to walk around the block because we'll go through that pain threshold and we won't be able to manage that. So we've got two things we can do. We can either not go around the block and avoid doing it, or we can lift up our tolerance levels, our barrier towards the pain, and so that I'm walking around the block now and I haven't got that pain anymore because I'm not going through that barrier or that level that triggers off the pain. A really important concept to get, because this is in effect how we manage our pain. We manage it by building resilience. We build in tolerance to pain. We build in a lot of attitudes towards pain. And one of the biggest attitudes that we say is, it might hurt to walk around the block, but now I know that walking is not harming it. I'm not wearing away my joints. It's just pain. So I might not be able to walk around the block, but I might walk just a little bit further in, and then I might trigger a little bit of pain, but then drop out of it. And then we're tricking the body over time to increase our tolerance levels. We don't want to go walking up the 1,000 steps in Ferntree Gully and really do a lot of pain, because then our pain stays high for a week.
Yeah.
So what we're wanting to do is build up the tolerance or the resilience. We have to go towards the pain. We're not afraid of the pain because we know that the pain doesn't equal damage. It hurts, but it doesn't harm me, which means that I'm building up the resilience. So in effect, I'm tricking the body to become stronger without me kind of stirring it up. So there's a fine line here, and it's not easy. That's why we really encourage you to do the supervised exercises. to find that balance between going close to it or above it even in a safe way that doesn't stir up the pain for long term, to trick the body to be able to build up that resilience and that tolerance to pain. And then over time, we increase. That's why we're continually progressing the exercises. Because if I got good at walking around the block, then I'll just walk around the block, and that won't be enough. I need to keep progressing to be able to build up. But hey, we don't have to run a marathon, so I don't need to get up here. We just need to build it up so that the things that I want to do around the house, playing with the grandkids, getting on the floor, getting off the floor, maybe going back to playing golf, that's at a level where I can manage it. So that's kind of what we do. I hope that kind of is clear and makes sense, because I think it's a really important kind of concept to get. One of the other things that is really important, which is part of the program, is to have a goal to achieve. What is the goal that we want to try and get to? What is it that we want to do? And what's really important is, because we know that pain is influenced by so many different factors, not just the structure of my knee, but other environmental factors as well, and my beliefs and stress and anxiety, or a whole lot of things, comorbidities, past experiences. So we don't focus on the pain so much. We focus on what our activity is and what our goals are, what we're trying to achieve. So one example is we had a woman, a grandmother in the program, and her goal was to be able to get safely on the floor and play with her grandson. She had a new grandson, and it's her second grandson, and she really wanted to be able to play on the floor with her grandson. She couldn't play on the floor with her first grandchild because she didn't have the confidence to get on the floor. So she missed playtime on the floor with her first grandchild, and the grandchild got older. It's running around now. So she really wanted to do that. So we developed a program around getting her, first of all, kneeling down safely, and then how to get onto the floor, how to get up off the floor safely, so that she was competent at doing it and wasn't in pain and could tolerate staying down on the floor for a while. And she was able to do that, and she was just thrilled because she was able to play with her grandchild. So, the pain doesn't really come into it as much as more what we're trying to achieve, what's important to us. So that's what we're always trying to kind of focus on, aside from the pain. And that doesn't mean that we're dismissing the pain and that the pain's not important. Absolutely it is. But it's more about managing that pain. It's the important part. We have to also understand that because of our osteoarthritis, we're far more likely to become fatigued. So fatigue, I describe, is different from tiredness. Fatigue is energy sucking. You just have not got the energy to do anything. So what we have to understand is that with osteoarthritis, we're more likely to have fatigue. We're more likely to have struggle with all of these motivation and tiredness as well, lack of energy. That's increased if we've got comorbidities as well, like heart disease or other chronic diseases, diabetes, say, for instance. But fatigue is also related to a lack of fitness or resilience or activity. So we also know that like when you're at high school and you're trying out for the athletics team, the fitter you were, the better you were at doing it. And we kind of relate that a little bit now to us, at a different level, far different level. But if we want to reduce our fatigue, we need to increase our energy levels to a point where I'm more active, and the better physical shape I am over time, the less fatigue that I'll have, because I'm just more able to do the things that I want to do. So this is basically how we manage arthritis. osteoarthritis. And this is the guidelines that have been drawn up on a number of different peak bodies. Arthritis Australia, the Royal Australasian College of GPs has an arthritis guideline that all of these guidelines around the world will recommend this is the treatment paradigm. So the green at the bottom is our first line of treatment, which is education, which is the first start of this you guys are doing now, which is fantastic. Understanding what arthritis is and how we manage it and what the good treatments are. Exercise, and I've talked about the importance of exercise. The stronger that we are, the easier it is for us to do things. It's as simple as that. And developing a good weight control strategy so that I can unload my joints a little bit more. And just on the weight control, there was a study that showed that a 5%, so it doesn't take a lot, 5% reduction in your weight can decrease your pain by up to 50%. So it's not a lot of weight that we may need to lose, and that's not to say that's everyone, but it's important to understand that losing weight, if that's an issue, is important. Now, our second line of treatment, our pharmacological, so our medication, our aids, and our treatments is our second line. So we, as physiotherapists and as doctors as well, will recommend this second line of treatment as long as we're doing the first line of treatment as well. We don't normally recommend that second line of treatment unless we do have a good education, exercise and weight control program happening. Because this second line of treatment, the evidence says that it can help some people, but it's not going to cure or fix the problem. It won't solve our problem. It won't make it easier for us to walk around the block in the long term. It might have short-term benefits, but it's unlikely to have good long-term benefits. So the things that I'm talking about are pain medication. So what we recommend with pain medication is Panadol, which is a good effective low-dose pain medication. Some mild anti-inflammatories like Nurofen can help as well, and that can really be effective for short-term benefits. What we don't tend to recommend, and certainly as you would have probably heard with the epidemic of opioid management or overuse, certainly in America and Australia especially, but all around the world. And there's very little evidence to suggest that long-term use of these opioids will help us. In fact, there's a lot of evidence to suggest that if we take opioids for long periods of time, our bodies become adjusted to that, and we need to keep increasing the dose to get the same effect. And of course, as you probably know, that the negative effect of opioid use is significant, and you know, can have caused a lot of deaths around the world as well. So that's what we generally do. But what we say as physiotherapists is consult your GP. Your GP is the first one to go and see when it comes to assisting your pain with medication. Then let's say passive treatment, so manual therapy, physiotherapy, massage, acupuncture, dry needling, all of these passive treatments. They can be incredibly effective at reducing some of your pain for some people. So we need to kind of work out what is the most important or the most benefit for me. But we have to understand as well, it's not going to cure the problem, it's not going to solve the problem, it will help. And it might be that it helps us temporarily to be able to make us more active. So if it helps to make us more active, then we're certainly going to be recommending that. But what we don't recommend is that we rely on these passive treatments, these manual therapy, if we don't have a good, strong exercise component to it that underlines it as well.
That's very important.
Aids, braces, and other things that can help as well. These are all incredibly effective. So a knee brace, say for instance, a walking stick, a hot pack that we put on, a cold pack, an ice pack that we put onto reliever. These are all great. So, for instance, a walking stick. If I can't walk around the block because I have pain and I go through that threshold, but then I use a walking stick and I can have less pain and I can get around the block. Fantastic. That's terrific. That's helped me to be able to get around the block. So we're going to recommend using that. Maybe that we can build up the strength and stability and the endurance so that eventually you don't need the walking stick, and that would be fantastic as well. But we're certainly going to say, well, if it helps you, then that's a good thing. So they're the kind of things that we kind of say. So this is just talking about how effective is the exercise is, and the kind of exercises that we do. Here are some exercises that we do within the program, which is stepping up. If we're having trouble getting up steps, well then let's develop a strengthening program to make it easier for you to get up and down those steps. And we do some lunges and some sliders, and we use these therabands here, these rubber bands with resistance training as well to build up the strength. The exercise is number one. And again, this is a quote from the RACP guidelines, just stating that they strongly recommend an exercise program as the first line of management. Then, as we said, that second line of management is braces and manual therapy. A lot of people come up and ask me, should I be putting heat on or should I be putting cold packs on my arthritis? What should I do? I'm getting a lot of conflicting advice, and Google doesn't really seem to have a standard answer as well. And it's simple. There's not a lot of evidence to suggest either way is going to be hugely beneficial. So what I say is, what your knee or your hip or your hands or your neck, what does it ask for? If you're spending a long time in the shower, and that relieves you, then maybe it's the heat that will be more beneficial for you. But for instance, if you go for a long walk and your knee blows up and it's now swollen and red and hot, then maybe an ice pack will help to reduce that pain and reduce the swelling as well. So there's no right or wrong answer when it comes to heat or cold. It's what your body is asking for. Orthotics can help as well for some people, because remember, for some people we get some bowing or some knock-kneeing, and orthotics can just help to unload the joint more on one side or the other. So that can help to unload the joint and provide some good relief. But again, it helps some people and it doesn't help others. So what we normally do is tape the foot, tape it so that it supports it, so it mimics an orthotic, and then we go away and go for a walk and see if that helps your knee pain or your hip pain. And if it does, then great. Then orthotics might be something that we try as well. When we're talking about the medications, Panadol and Nurofen tend to be the best ones. Bigger, stronger anti-inflammatories like Voltaren can be very effective as well, but we don't want to really use them for long term. And it's definitely the most important thing is to get some advice from the GP. The other thing that people often ask is, should I be putting those topical gels on? You know, I've got some Voltaren gel, or there's some natural gels. And my answer to that is, some people find them unbelievably effective. Other people find them difficult. So if that's the case, then I say, well, try it, and if it helps you, do it. But if you don't really find it gives you any relief, then it doesn't really. I don't think that it's going to be something that you need to pursue. It's not going to change. If it helps, use it. If it doesn't, don't bother. And this is, we're just saying that we don't want to use the morphine-based, the opioids. The other thing to consider too is supplements. Should I be taking some glucosamine or chondroitin. What about turmeric? People are telling me I should be taking turmeric as well. Now, there's not a lot. So we used to think that there was evidence, but the evidence wasn't really robust. There's a lot of evidence and research coming out now, and a lot of the research says that it doesn't really have a big, strong clinical effect. But again, if somebody says to me, I've been taking glucosamine, it's really helped change my pain, I think you should keep taking it because it's really helping you. So again, it's more, if it's going to help, if it helps you and you find that it works, then do it. But there's not a lot of strong evidence. So if it doesn't help you, then don't bother. And that's generally what we do. So I don't tell people to take it. I don't tell people not to take it. I tell them to work it out for themselves. I'm okay with taking it. But if it's not doing doesn't have any benefit for you, it doesn't give you any relief, save your money, really. And then the injections, we have cortisone injection. Cortisone can be very effective at reducing pain, but it doesn't last forever. And we often use it as a window of opportunity. This cortisone injections help settle down your pain. So let's use this opportunity to build strength and resilience. So this is my pain levels. Remember again, cortisone might have just now lifted up my tolerance. So now I can walk around the block. I am going to walk around the block a lot to build up my resilience. And that's going to be really important to do. We do have to understand too that it doesn't work for everyone. Some people it doesn't work at all. And we also know that the evidence is suggesting that if we have too many cortisones over time, then that can lead to an increase in the degeneration that's happening in our knee. So we don't recommend ongoing cortisone injections. There are other injections that we can have, Synvisc or hyaluronic acid, which tries to mimic the synovial fluid in your joint, the fluid in the joint fluid. This again can have a really profound effect on some people, but not a lot on other people as well. And it also hasn't got a long term. Its effect is limited as well, but it can be. It's costly though, so that's the fallback for that. The same with PRP or blood injections, as some people have said. These can be effective for some people, but there's not a lot of strong evidence to suggest that over a general population they're going to have a big effect. Again, they're quite expensive, so this is a sometimes or something that you might try, but it's certainly not going to solve the problem. The other thing that people ask is stem cell therapy. When's that going to be the next big thing? They're doing a lot of research at the moment on stem cell therapy, a lot of research, putting a lot of money into it. And you might have seen on news that there's round the corner, they're having some really good trials, but generally speaking, it's still a while off to be effective. They haven't cracked that nut just yet. So then surgeries, which is the last point on the pyramid. Two types of surgery that generally happen. One is the arthroscopes. So with the arthroscopes, they'll put a little cut in there and they'll clean out the joint, trim away some of the shag pile, articular surface, and any floating bodies that are in there. And we used to do that a lot. Huge amounts of arthroscopes done every year. The problem is, guess what? They don't work. They don't work, and there's a lot of evidence that we thought they worked, and we think that they have a short-term effect, and placebo certainly comes into that a lot as well. But long-term effects with any surgery that happens anytime you cut into the knee, there's a good chance that it might actually increase the rate of degeneration. So much so that Medicare is now not funding for any hip arthroscopes because there's no evidence to suggest that hip arthroscopes are effective at all. Knee arthroscopes is a little bit different because we do have this floating cartilage, remember this meniscus, and sometimes we can get a tear in that and the joint becomes locked and there's a big clunk or clicking, and in that case it is necessary to have an arthroscope to be able to free that up so that we can get that knee moving again. That's when we will recommend that, but not so much for anything else. So this is and then they do have some risks as well, but a lot of the studies suggest that it's actually no better than sham surgery. And they did one study that they went in there and they just did these 2 little nicks on either side, but they didn't actually go into the joint itself, didn't actually do any surgery. And they found that those group of people just got just as much benefit as the ones that actually had the real surgery. There's not a lot of evidence to suggest that that's going to be effective. Then the other type of surgery is a joint replacement surgery, and this is an incredibly beneficial way of solving someone's knee pain or hip pain because they can be incredibly effective. 80% of knee replacements are beneficial, 95% of hip replacements are successful. So there's a really good hit rate. The problem is that if we're weak and we have poor strength and activity levels to start off with, so our bar is quite low, then a joint replacement is not going to solve that. It's just going to mean that we're probably going to end up with the same problems, just, nothing's sort of changed. So we're recommending that, and certainly the surgeons who refer a lot of their patients into our program before they'll even consider doing a joint replacement surgery. So the surgeons now are saying, well, if you haven't done a good, robust rehabilitation program first, then I'm not even going to consider you for knee replacements. But here's the thing: if we've done a good education, exercise, weight management program, and we've done that, we still have a lot of pain associated with joint degeneration, then we'll certainly consider a joint replacement surgery because they can be very effective. What we're finding with these programs is there's the data's coming out at the moment, but we're getting up to a 1 to a 2 year delay in the need for that arthritis, osteoarthritis need for joint replacement. So we're delaying it. We're taking costs away from the health system, and a lot of the time we're preventing those unnecessary surgeries. So someone coming in with very limited activity levels and a lot of pain, increase their strength and resilience and drop their pain levels, and they don't need to have the surgery at all. And that's a real great success, and that's a real something that certainly happens. So this is our treatment paradigm, and that's the way that we basically approach all of our people with hip and knee arthritis. So when we're talking about hand or neck or back arthritis, it's exactly the same. The only difference is that our exercises are going to be different. So we're not going to do so much steps or stairs, but we might do some other back strengthening exercises or neck strengthening exercises with resistance and stability, and that's really important. Same with the hand. We're going to do a lot of resistance exercises so that over time we get more strength so that I can cut that pumpkin, I can do that gardening, I can do that sewing and that fine needlework that I really enjoy doing, but that was getting in the way because of my pain. So this is the same approach that we have. But this is the I guess the results. We have reduced pain. it's really important that we understand that it's the quality of life that we're aiming for, as opposed to the reduction, the main focus is reduction in pain. If we can get that quality of life increased, then guaranteed you're going to have reduced pain regardless anyway. But here's the thing as well is, well, I still have pain after I walk, but now I'm walking 9 holes of golf, which I wasn't walking before. Sure, I still have pain, but I'm able to do that now as well. And isn't that great? Because before I couldn't do it, and now I can. But I still got pain, but I also understand a lot more about my pain and how it impacts me. And as a result of walking around 9 holes of golf once a week, I've reduced my weight, and it's becoming easier and easier for me to walk as well. So that's a great thing as well. And as a result, I've cancelled my appointment for the surgeon, because I don't think that I need that joint replacement that I was thinking that I did. So that's a little bit. That's the end of the talk. I'm very happy to take questions now, but if you prefer, I'm very happy for you to give me a call. I think I sent you an email. If not, let me know, and I will send you my details so that you can call me or email me. I'm happy to do that, to take it offline. But if anyone's got any questions now, just unmute yourself, and I'll be able to answer your questions.
Yes, Tom, I was wondering, osteomole, the treatments of the pain, is that a safe medication?
Osteomole. Is that a type of medication, Len, is it?
I believe so, Tom. It's for my wife. My wife's having the problem with the hip. I'm fine. I walk around the block every day, and I do 3Ks a day.
I think osteomole is a type of paracetamol, which is similar to the slow release Panadol, or Panadol Osteo. And and that is, from what I understand, Len, that is a mild painkiller, which is slow release. So you take it 2 in the morning, 2 in the middle of the day, 2 at night, and it's a slow release Panadol, rather than a Panadol that'll fix my headaches. It's more slow release, and that's why they target it at people with osteoarthritis.
Well, thanks very much for that, Tom. Thank you.
No worries. Anyone else?
And thanks for the information.
Oh, great,
excellent.
Len, I'm glad. So happy for you. So I will as well, everyone, send you out some information about our program, some details. We have the classes that run all throughout the week, some in the morning, some in the afternoon, some are in the evening, and there's a couple on the weekend as well. But all we need to do is join any class that you want and try and do it twice a week. We can teach you the exercises to do at home. That's not a problem. But the research says that we know is that you're going to get a much better result if we supervise you, and that you do it in a group to motivate each other as well. And it's a lot more fun, and we find that people progress a lot quicker if they do it in that group environment as well. So I'll send you a little bit of information about that when the classes are on, as well as costs involved as well, and a little bit of the some evidence and some other literature as well. And I'm recording this, so I'll send you a link to this if you want to either forward this on to a friend or forward my details onto a friend. I'm happy to talk to anyone, but feel free to, you contact me to make sure if you want any more information.
Well, thank you very much,
Tom.
Yes.
Tom, mine is in the feet and the hands.
Yes, feet and hand arthritis, as we said, Diana, is one of the more common areas. The way that the people that we see with foot and hand arthritis, they don't generally go into these programs because the exercises are different, but we do set up different programs for them, which again are targeted towards building strength and resilience in the hands and the feet. One thing that we do know with the hands and the feet as well is that, remember, we're balancing between the load, overload and underload. And sometimes, because the hands get worked all the time, is that we need to protect the hands more and to support the feet more. So it might be that we need to get a wrist splint or a hand splint, can be, or a thumb splint, because a lot of people get arthritis in their thumbs. And so, yeah, and so a thumb splint, a customized thumb splint that's molded here, not very expensive, but they can be incredibly beneficial. The ones that we like to use support this area of the thumb as well, but still allow you to function. So there's still, you can, and some people say, well, I can now sew with it because it's more comfortable for you. We also manage foot and hand a little bit differently. So feet and hands tend to get more relief with manual therapy, so joint mobilization to get the movement back into them, and that can be one of the big things. If we're talking about walking, one of the big things is that, again, like the thumb, the big toe, the big joint around the toe, and it doesn't like bending back. And so that, yeah, and that's a big part of foot arthritis in that part of the foot. So when we push off, it hurts. So what we're trying to do is get that range back, so increase that range. And once we get that range, we find that a lot of people have much reduced amount of pain. We also know that around the foot, the calf strength really drops. And so building up the strength in the calf is a great way to help build up that strength to reduce the pain. The other thing is we'll look to get an orthotic to support the arch of the foot a lot more, because that can really support the foot. And look at footwear as well, and make sure we've got supportive feet. So there's a lot we can do with hands and foot arthritis, which is going to be different from the way that we manage hip arthritis.
But it was very interesting. And I come from a family that has both arthritis, so it was interesting.
Yeah, well, we didn't talk about rheumatoid arthritis. And rheumatoid arthritis is a little bit different, or I should say very different, because rheumatoid arthritis is an inflammatory condition, and it's not so much a degeneration. So it's not about the regeneration and degeneration of the articular surface. It's inflammation, an inflammation process that happens around the joint. So it can be just as debilitating. People with rheumatoid arthritis are much more likely to get osteoarthritis as well, just because of the disease components to it as well.
Thank you very much.
No worries. Anyone else? Great. Well, we might end it there, and I will, I will send out an email to everyone with some information. And if you have any questions, feel free to either call me or drop in. We're still operating, we're still treating, and we're still doing the classes, although the classes are normally 4 to 5 people. We're reducing them for our restrictions, and they're only 3 people per class now, but that's even better for you because you get more attention. But it's a different feel, because the more people in it, it's more vibrant, but it's still just as effective. So terrific.
Right. Thanks again very much, Tom.
Right. Thanks, everyone.
Thanks, Tom.
All the very best. Thank you.
Thanks. Bye.
Bye.
Bye.